Let's talk about the strategy and surveillance of antimicrobial stewardship. Antibiotics have transformed the practice of medicines. Like all medications, antibiotics have serious adverse effects, which occur in nearly 20% of the hospital patients. These are treatment failures, caution difficile infections, adverse effects, antibiotic resistance. 2014 CDC called all the hospitals in the United States to implement stewardship programs and release the core elements of stewardship program. The core elements outline the structural and process components that are associated with successful stewardship programs. The core elements are intended to be an adaptable framework that hospitals can use to guide efforts to improve antimicrobial. Core elements include hospital leadership commitment, accountability, pharmacy expertise or drug expertise, action, tracking, reporting, education. Let us see about the core elements in details in the next section. Which is to see our leadership commitment. What does this indicate? It gives stewardship program leaders time to manage the program and conduct daily stewardship interventions. Then it includes providing resources, including staffing to operate the program effectively, have regular meetings to assess the resources to accomplish the goals, appointing a senior executive leader to serve as a point of contact or champion to help ensure that the program has the resources and support to accomplish its mission. And reporting stewardship activities and outcomes to senior leadership and hospital board on a regular basis. The other leadership commitment include integrating the stewardship activities into other quality improvement and patient safety efforts, having clear expectation for the leaders on responsibilities and outcomes, making formal statements of support to improve and monitor antibiotic usage, outlining the stewardship related duties in job descriptions and annual performance reviews for program leaders and key support staff, supporting training and education for program leaders and hospital staff, supporting participation in local, state, and national antimicrobial stewardship quality improvement collaboratives. Then the leadership committee ensures that the staff from the key support departments have sufficient time to contribute to the stewardship activities. And the staff includes clinicians, departmental heads, pharmacy therapeutic committee members, infection preventioners, quality departments, microbiology, information technology professionals. The antibiotic stewardship program must have a designated leader or co-leaders accountable for program management and outcomes. Most hospitals have found a co-leadership model to be effective. Programs with key co-leaders should have a clear definition of responsibilities and expectations, especially important for physician leaders who do not work full-time at the hospital. If a non-physician is the leader of the program, it is important that the hospital designate a physician who can serve as a point of contact and support for the non-physician leader. A regular stewardship round for the co-leaders or the non-physician lead and the supporting physician are must. Discussion with the prescribers such as handshake stewardship has been shown to improve antibiotics. Now, what does the team structure look like? It consists of physicians, including microbiologists, infection control experts, IT experts, physicians, pharmacists, and nurses, the hospital epidemiologists, hospital administrations, and clinical pharmacists. The roles and responsibilities. The physician leaders develops and implement the AMS program, sustains the AMS program. But the hospital administration provides formal support to the AMS program, provides resources. Pharmacist co-leaders support the team leader responsible for daily AMS tasks. The clinical microbials provide diagnostic support. IT experts develops and implements and maintains the IT. Infection control professional provides infection control support. The key physician, pharmacists, and nurse stakeholders provide input during development and implementation of the AMS. Regarding pharmacy expertise, they are highly effective. Hospital and antibiotic stewardship programs have strong engagement of pharmacists, either as a leader or a co-leader. It is important to identify pharmacists who are empowered to lead implementation efforts. They can be either infectious trained pharmacists or general clinical. What are the actions and stewardship intervention improve patient outcomes? An initial assessment of antimicrobial prescription can help identify potential targets for intervention. This can be priority interventions, common infection-based interventions, other infection-based interventions, provider-based interventions, pharmacy-based, microbiology-based, and nursing-based interventions. How to do the assessment of the 7 core elements? The checklist given by the CDC for core elements of hospital antibiotic stewardship program, which includes leadership support, accountability, drug expert. What are the actions included in the antibiotic stewardship program? This is priority interventions, which includes prospective audit and feedback, then pre-authorization and facility-specific treatment guidelines. What do you mean? I mean by prospective audit? That is selection and identification of the patients, primary review by the ID pharmacist, then secondary review and evaluation of cases by the team, And then if it see we check assess whether there is an optimal antibiotic usage as per choice, duration, dosage, and route. If yes, it's entered in the database entry and analysis is done. If it is no, then the interventions are employed and the immediate current feedback is given to stakeholders. What do you understand by pre-authorization? That is antibiotics require pre-authorization are carefully selected based on variables such as broad spectrum, potential to promote resistance, potential for misuse or overuse, high cost, risk of serious adverse effects, and need to reserve for treatment of multi-drug resistance. Developing specific guidelines or antibiotic policy involves steps such as identify the most important common ID syndromes in the hospitals, integrate the care model guidance of the specific clinical syndromes, evaluate the most common pathogens causing those syndromes, evaluate the most effective antimicrobials against them. All the information into an algorithm and to develop the specific hospital. Now, what are the general principles for antibiotic usage? What is the diagnosis? How severe is the infection? Is the patient immunosuppressed? What is the risk of infection? Does the patient have an antibiotic allergy? What is the status of patient's renal and hepatic function? All these factors need to be considered during the antimicrobial usage. What is the infection-based interventions? This includes more than half of the antibiotics are going to treat infection in hospitals. Where there are important opportunities to improve usage, this includes respiratory tract infection, urinary tract infection, skin. So stewardship interventions in this category, in this actions include to have diagnostic considerations, have rational empirical therapy, and tailor the definitive therapy according to culture results and sensitivity. Action-based intervention also includes management of sepsis, staph infections, C. difficile infections to have proper and rational guidelines for. It includes provider-based interventions such as antibiotic timeout. Provider-led reviews of antibiotics can focus on four key questions. Does the patient have infection? Have proper culture and sensitive results been performed? Can antibiotics be stopped or is brought to narrow or IV to oral switch, that is de-escalation? How long should the patient be received antibiotic? And then assess the patient's. That was about provider-based interventions. Now, pharmacy-based intervention includes documentation of the antibiotics indication and to automatic changes from IV to oral or broad to narrow, dose adjustment, dose optimization, duplicated alerts, time-sensitive stop orders, and detection and prevention of antibiotics. If the hospital's empirical treatment guidelines have not been followed without a valid reason, the pharmacist should recommend that broad-spectrum therapy be discredited. With empirical therapy, narrow-spectrum antibiotics should be chosen in accordance to treatment guidelines. Once microbial results are available, the pharmacist should encourage the change to definitive therapy with as narrow-spectrum treatment as possible based on culture and. The criteria for de-escalations. This includes criteria for de-escalation via switching to narrow spectrum, such as for empirical therapy, it includes temperature less than 38, not on inotropes, usually BP return to baseline for or more than 100 mm, not mechanical ventilated, a fraction of the inspired oxygen less than 0.4, respirator less than 25 breaths per minute, and saturation of oxygen more than 92%. For definitive therapy, the de-escalation criteria includes de-escalation to narrow spectrum or IV to oral based on culture and sensitive results. Now, IV to oral conversion of the same antibiotics is a relatively simple intervention, and pharmacists should routinely encourage IV to oral conversions of antibiotics with good bioavailability in eligible patients. For example, fluoroquinolones are highly bioavailable drugs that can be easily convertible from IV to oral route. Advantages of the oral therapy include ease of administration, early discharge opportunities, decreased IV-related adverse events, and drop drug cost. Regarding dose optimization, pharmacy expertise in relation to pharmacodynamic and pharmacokinetic principles is particularly beneficial when reviewing the antibiotic regimens for dose optimization. Dose optimization can be implemented by pharmacists on the basis of identifying deviations from recommended guidelines and making recommendations to optimize the dosing. However, in critical inpatient dose optimization by therapeutic drug monitoring will help ensure adequate. Now, that was about the pharmacy-based interventions. If it's the microbiology-based interventions, this includes selective reporting of the results, comments providing comments in the microbiology reports, and nursing-based interventions include optimizing the cultures, IV to oral transitions, and prompting the antibiotic. Thank you. That's all.